All right, well, good evening, everyone. My name is Paul Rowley. I'm a fourth-year medical student at the University of Wisconsin. I'm pleased to have a panel of experts from the University of Wisconsin here to speak on a complex, interesting, and really a topic which is not discussed enough, parathyroid venous sampling. I'm here with Dr. Sippel, a endocrine surgeon here at the UW, Dr. Pinchot, an interventional radiologist, and Dr. Avey, a neuroradiologist here at UW. Without any further ado, I'll let them start. Dr. Sippel.
All right, great. So I'm going to share my screen. So hopefully that works. Are you guys able to see my slides?
Yes.
Perfect. Awesome. Well, I really appreciate the opportunity to be here to talk about something that I'm very passionate about. I think this is a great presentation, sort of having our different perspectives, because this is, doing complex parathyroid surgery is really important to have a multidisciplinary team. And so I was going to start with just a little bit of background, because as a radiologist, you may not know a lot about primary hyperparathyroidism, but it's my life. That's what I think about. So we have about 100,000 new cases each year in the United States, and it affects about 1% of the general population. It is definitely more common in the elderly and occurs in about 2% of patients. But this condition is really underdiagnosed and undertreated. So I think the more we raise awareness of this, the more patients that we find. When patients have this, it's basically autonomous parathyroid hormone production from one or more parathyroid glands. The good news is that 80% of people have a single adenoma. I mean, it's just one gland that's enlarged. And so that's great. And those are ones that are much easier to find on imaging. Unfortunately, the challenge is that about 20% of people have more than one gland. They can have a double adenoma, or they can have hyperplasia, which is enlargement of all the glands. And those glands are located in ectopic locations in about 5 to 10% of the time. And so parathyroids embryologically start underneath the jaw, and they migrate down, and they're supposed to stop near the thyroid, but they can end up all the way down to the heart. And so when they're in those unusual places, it can be much harder to find. So one of the things I think about as a clinician treating this, and one of the things I always ask patients with parathyroid disease, is the first thing I have to do is clarify, do they actually have the diagnosis? Are the labs consistent with it, and am I confident that they have primary hyperparathyroidism? And then once I make a diagnosis, I want to know, are they going to benefit from surgical treatment? Just because they have it may not mean that they need to have surgery. But if I'm confident of the diagnosis and I'm certain that they would benefit from surgery, then I want to think about really what's the best surgical approach that's going to be used to help that patient. And that is the time period that I really start to consider imaging. I think too often imaging falls earlier in trying to confirm the diagnosis, and I think the key is it really helps us to guide our surgical planning. So I think it's important to recognize that preoperative localization doesn't confirm or make a diagnosis. It really just lets us know as surgeons what approach to use and where to start looking first. And I think it's really important that we always make sure that the diagnosis is sound and that there's clear indications for surgery before we start ordering imaging. Because like any test, there's going to be false positives and things that can be misleading on imaging. So when do we order parathyroid imaging? I would say the reliance of parathyroid imaging is directly related to experience. Patients with negative imaging get referred to tertiary care centers, and I think newer surgeons or less experienced surgeons tend to order more imaging. As someone who's done this for a long time, I tend to be more of a minimalist with imaging for a first operation, but a large part of my practice is reoperations, and those are a totally different story. And I would say that ideal is I want dual localization, and in an ideal world, I actually want functional and anatomic localization. I want to know not only that there's a structure there, but that that structure is overproducing parathyroid hormone. So how do we approach it? I would say for all of our patients, we do a neck ultrasound in clinic on everyone. If it's positive and we find what looks like a clear-cut parathyroid adenoma, I don't order any further imaging. We just take them to the operating room. But if that ultrasound is negative, then I want to assess the likelihood of multi-gland disease, kind of assess the anticipated difficulty of the case. And I would say that, the ultrasound, the reason I like it is because it's non-invasive, it's quick, there's no radioactivity. But the challenges with ultrasound is it's very operator dependent. So if you don't know what you're looking for, you can very easily miss a parathyroid because you're just not certain where you're looking. So what if the ultrasound is negative? What is next? Again, I kind of asked the question, well, how likely is it that they have multiple enlarged glands? Do they have really mild disease? Do they have a family history? Do they have lithium exposure or a history of chronic kidney disease? All of those things are going to make multi-gland disease much more likely. The other thing I want to look at is how difficult is the case going to be? Have they had prior neck surgery? Have they had prior radiation or radioactive iodine? Do they have thyroiditis or a big goiter? Do they have difficult anatomy? Is their thyroid really low setting down in the neck? Is their neck fairly thick? And based on that, it may decide to order additional imaging. And I would say that the two imaging of choice that we typically do for our second line are either a 4D CT scan and a technetium-99 system Avey scan. And Dr. Avey is going to talk about those. I would say CT scans are really helpful when somebody's had a larger neck. So when we look at this neck, trying to find the tiny little grain of rice or jelly bean parathyroid, it's really helpful to have some imaging guidance. Or if there's prior neck surgery and there's a lot of scar tissue. System Avey scans can be helpful, especially if somebody's got concurrent Hashimoto's thyroiditis and the thyroid just has a ton of blood flow and there's a lot of reactive lymphadenopathy. It can be very difficult to discern what might be a lymph node that's reactive versus a parathyroid on most imaging scans. It can also be helpful if there's concern about ectopic glands, especially if there's a gland down in the chest that we may not appreciate on a CT scan or an ultrasound. So our goals at surgery are really to distinguish between unilateral adenoma and a multi-gland disease. If it's a single adenoma, we want to resect it. And if it's hyperplasia, we want to remove 3 or 3.5 glands, really do a subtotal resection. And the goal is to clear the neck at the first operation. And thankfully, we usually have about a 95% cure rate. Unfortunately, not everyone's cured at that first operation. And, I think why do these operations fail? Somebody misses an adenoma, whether it's in an ectopic or a normal location, they just didn't appreciate it was there. They had multiple abnormal glands and they only removed one. They might have parathyroid cancer, parathyroidomatosis, where there's implants of parathyroid tissue all around the neck. Or they did a subtotal resection of a parathyroid tumor. They thought they removed it all, but they only took out 80% of it and that piece grew back. Or they have a familial disease where they have a genetic predisposition and they just keep regrowing parathyroid tissue. So how do we approach these patients with recurrence or persistence? I kind of go through the same questions. Do they have primary hyperparathyroidism? I want to clarify the diagnosis. So we want to first confirm that a diagnosis was right the first time. Then I want to verify that they're going to benefit from surgery. I want to verify there truly are indications to treat this and then it's going to be beneficial to the patient. And once we confirm that, then we want to think about what surgical approach. And unlike a first operation where I'm not really concerned about the imaging, on a reoperation, it's absolutely clear localization is truly essential. We can't go in a scarred-in neck without having some concept of where that parathyroid is located because it's just the risks far outweigh the benefits. Again, for a reoperation, I ideally want both anatomic and functional imaging. So when I'm looking at anatomic imaging, it's either a neck ultrasound or a 4D CT scan. So here's an example. There's a hypocoque structure that I see in ultrasound. It has a single arterial pedicle. It looks suspicious, but I don't know for certain that's a parathyroid. That could easily be a lymph node or something else. So I want to get some confirmation that there's some function. So I get the system Avey scan and I see that that area lights up and now I've got functional confirmation. There's a structure on imaging and it lights up on a system Avey scan. Then I feel much more confident that that's going to be the source. So for functional imaging, I would say system Avey scan is our first choice. Sometimes if it's visible on ultrasound, we can actually do an FNA and send it for a parathyroid hormone level, and that can be diagnostic. But for those patients where it is just not feasible to do these or the system maybe is negative, that's where selective venous sampling comes in and has been a real advantage for our program. So this is just an example of combining localization. This is a reoperative patient I saw, and this was read as a possible right lower. And I would say that for a reoperative setting, this is not an imaging that I was willing to sort of operate on. But we got an ultrasound, and then we could see a clear anatomic correlate on that ultrasound. So I would say once I see the imaging and I see some functional confirmation, I'm much more confident that that truly is probably the source, and I'm willing to offer surgery to somebody. So what are some of the indications for selective venous sampling? I would say really, I think this is not something you're going to do for a first operation. But I think for reoperative cases, especially with those that are negative or unclear localization, or if the anatomic localization is in a difficult to reach or an unusual place. This often happens, we find something on a CT scan down in the chest, and it may be a parathyroid, but we're just not certain. That's a great utilization of the selective venous sampling to kind of clarify that, yes, there really is elevated hormone production coming from that region. All right, so that is my part, and I'm going to pass the baton on to Dr. Avey, and then I'd be happy at the end we can answer some questions about this.
Perfect, and I'll work to share my screen here as well. Okay, I think we're all seeing my screen here. So first of all, I want to thank you for the opportunity to give this discussion. This is a big part of my practice and part of my practice that I really enjoy because it's challenging. So we'll kind of go through some of the ways that I help try to find parathyroid adenomas before we get on to Dr. Pinchot discussing the venous sampling. So I don't have any financial disclosure to talk about, no off-label uses will be discussed, but I do want to say that parathyroid imaging is one of the most challenging areas of the head and neck. We recently had our big national meeting at the ASHNR, and this was a persistent topic, and I think it's honestly something that all of us who are in this field find is one of the most challenging things that we do on a day-to-day basis. So for this talk, I'll review some of the imaging modalities that we use for localizing parathyroid adenomas. I'll review the relative accuracy of each of the tests. I'll discuss the 4D CT technique, just because that's probably currently the most common and one of the more accurate ways that we use to find parathyroid glands. And then we'll do some representative cases on 4D CT, just so you sort of know what we might be looking for each of those little tiny glands. So this was a case of 67-year-old male, serum calcium level 10.5, so mildly elevated, a PTH of 136, multiple renal calculi, and they performed a sensitivity scan. So we've got our early and our delayed sequences here. And if you were to take a look for it and try to decide where you might think a gland would be, I'll kind of let you think about it for a little bit, and then we'll kind of take another look as well. So if you were to localize the adenoma, or reading this case, would you think it's on the right or the left, or would you really just say, I'm not sure, can I really localize this, lesion? So planar imaging, although we show it occasionally, it's seldom performed currently as an isolated study because the sensitivity is relatively low, only about 70%. Specificity, if we really do find a convincing lesion, can be relatively high, 84 to 93%. This is that same patient done with SPECT imaging, and here we can see the early images, late images, and in this case, I think it makes it a lot easier to see where the adenoma is. So in this case, the SPECT CT is going to have higher sensitivity just because we do get those multiplanar images. Sensitivity is about 86% with specificity, again, relatively high in the 80 to 90% range. So in this case, we can see this area of persistent uptake left lower, kind of along left lower lobe of the thyroid gland there at the 2-hour mark. And then on the SPECT CT, we can have greater confidence as well. We're kind of seeing that increased activity there. So something that can help us at least is we're locating very relatively difficult to find glands. In this case, we can also use ultrasound, just like Dr. Sippel had mentioned. This is a nice lesion demonstrating ultrasound. It's relatively hypoechoic, a little bit of kidney bean sort of shape with a polar artery and quite a bit of vascularity around it, all of which are relatively classic for parathyroid adenomas. So you better believe, again, these are some of my most difficult cases. So when I'm pulling these up, I'm oftentimes looking at the surgery report to say, you know, what they found in clinic, because oftentimes there is an in-office ultrasound performed, and that can really help inform my read as well if they found something I need to really investigate. And so it's really sort of that team approach to approaching these lesions. So again, on ultrasound, we're looking for a hypoechoic gland compared to the thyroid. It should be oblong or oval in shape, and then with a peripheral or polar vessel extending into one pole of lesions, and almost kind of a ring of fire when you turn on the color flow around it. Ultrasound sensitivity, actually it's pretty good, the 90 to 95%, but again, that's depends on whose hands that it's in. You know, I'd say honestly a surgeon who really knows what they're looking for and is aware of what they need to investigate, they're really quite accurate at finding particularly large glands. Smaller glands, multi-gland can be a challenge for all of us. And specificity is relatively high as well if we can see those particular signs, 73 to 95% specificity. So in this case, The patient underwent parathyroidectomy using both ultrasound and gamma probe for localization. They found a single 510 milligram adenoma on the lateral surface of the lower pole, just like we see here. So oftentimes, if we have somebody who's coming in, it's a reoperation, a difficult neck, something else like that, we'll be getting 4D CT as a way to help investigate and find those adenomas. Most commonly used for troubleshooting purposes, say recurrent hyperparathyroidism, prior neck surgery, or if we just haven't been able to localize it with other modalities. At the University of Wisconsin, we do 3 phases. We do a non-contrast phase, an early arterial phase, and a washout phase. Sensitivity of 4D CT is pretty high, somewhere in between which you look at, 76 to 92% with a specificity of somewhere between 82 and 96%. So if we're sort of comparing the modalities we looked at so far, we can see sensitivity is gradually growing until we get to 4D CT. Still, honestly, not perfect. This is where Dr. Pinchot is going to come in just a little bit to discuss those difficult cases where we end up going for venous sampling. If we can find a convincing lesion, the specificity can be relatively high. The problem is that oftentimes the patients, especially in my practice, that I get sent because Dr. Sippel is such an amazing surgeon with a large referral base, we really get sometimes the difficult cases and difficult necks. And so I would suspect that our sensitivity may not always be quite 90% just because we're oftentimes looking for difficult or ectopic glands. And just as a reminder, we look all the way from the angle of the mandible through the anterior mediastinum to look for these little tiny lesions that can be as small as just a little larger than a grain of rice. So it certainly is a challenge for an imaging modality. What does the technique look like? Well, we take advantage of the fact that parathyroid glands are highly vascular. And so that real increased vascularity results in early enhancement during a CTA sort of phase, so an early arterial phase, and then it washes out during a delayed phase. So the classic parathyroid adenoma enhancement pattern is shown below here, where it's going to be a little bit hypodense compared to the thyroid gland on non-contrast images. We're going to have early arterial enhancement on the arterial phase, and then a little bit of washout on the washout phase. That's going to be a pretty convincing pattern for a parathyroid adenoma. But the question is, that's sort of what it ought to look like. But not all of our parathyroid adenomas have read the book. So people have looked and said, how often do we actually see that sort of classic pattern? They divide it into these A, B, and C glands, which A being a classic hyper-enhancing gland, B being hypo-enhancing compared to the thyroid and arterial phases, but then wash out, and C being a gland that really just kind of gradually starts to take up contrast more and more over time. And interestingly enough, when we ran the numbers, about 20% of glands were actually the classic sort of hyper-enhancing and washout glands. 57% showed some enhancement, but not as much as the thyroid gland, and then washed out. And some of them, about another 22%, actually just persisted to increase in enhancement over time. So really sort of any enhancement pattern, it can potentially represent a parathyroid adenoma, just so long as it's enhancing more than the adjacent lymph nodes, which only serves to help complicate the challenge of finding these difficult glands. So again, this is our protocol here. We do 3 phases, a limited non-contrast neck, and that's really to help us distinguish the parathyroid gland from thyroid tissue, which should be intrinsically CT hyperdense. Then do an early arterial phase at about 25 seconds, and then a delayed phase at about 60 to 80 seconds. So we'll do just a few cases to help find the parathyroid gland, show where some of these things might be helpful. This is a 58-year-old with a history of hyperparathyroidism, also had a history of facial nerve palsy due to resection of vestibular schwannoma, and then she'd had prior neck surgery to do muscle transfers and improve facial tone. So obviously a neck that had multiple surgical procedures before. So we did a 4D CT to help localize the gland. So this is our early arterial and our washout phases. I think this is a nice job of showing why it is we don't do a single phase. And you can see on the early arterial and washout, the gland looked pretty homogeneous. There's really not any obvious enhancement in any particular area that might suggest a isolated parathyroid adenoma. But when we bring up the non-contrast study, we can see this portion of the gland looked a heck of a lot like a little thyroid nodule extending from the posterior margin of the gland. Actually was CT hypodense on the initial non-contrast, so not containing iodine like the rest of the thyroid gland we typically consider to do, and that actually turned out to be a parathyroid adenoma. So that non-contrast study can be really helpful, especially for glands that are right adjacent to the thyroid parenchyma. This is another case, a 74-year-old with a history of prior parathyroid gland surgery. They removed 2 prior glands, but a failure to correct the hyperparathyroidism. So we know if there's a gland around somewhere, but the question is, where is it? So here's our non-contrast, here's our early arterial, here's our washout phases. we kind of scan the typical areas we would expect. So along the posterior aspect of the mid portion of the thyroid gland, we might look in the tracheoesophageal groove or along the inferior aspect of the thyroid lobes bilaterally. Didn't find anything there, but as we scrutinized the thyroid parenchyma, we realized there was one area that was non-contrast, a little bit CT hypodense, showed some early arterial enhancement, and then did some washing out. So that is the adenoma, and surgically proven within the posterior aspect, kind of within the thyroid capsule or directly adjacent to the thyroid gland. That was even just a relatively small 4mm adenoma. This is an 82-year-old female with history of osteoporosis and hyperparathyroidism. Also had a history of prior cervical spine fusion, and so again, potentially increasing the surgical difficulty. So we can see this is our early arterial phase. This is our washout phase. We sort of look through, and I think after a while, some of the more common sites at least start to pop out at us. So again, we look in the tracheoesophageal groove. We look along the posterior aspect of the mid portion of the thyroid gland, and we look along the inferior aspect of the thyroid before we start really looking for the ectopic glands. Again, anywhere from the angle of the mandible through the anterior mediastinum. And here we can see again a relatively hypodense parathyroid adenoma, and then early arterial, a little bit of enhancement, and then a little bit of washout as well. So again, this one's showing at least some enhancement, some washout, probably either a type B or a type C. This is a 55-year-old male with history of hyperparathyroidism. Prior surgical exploration had been unable to find a causative adenoma. So here we're a little bit lower, below the level of the thyroid gland. We can see our non-contrast phase, or the arterial phase, where we're actually washing in contrast from the left side of the left subclavian. And then here we can see the washout or the delayed phase. When we take a look at this and scrutinize it closely, I think it's difficult, possible to see. We do have enhancement on the early arterial phase within this lesion posterior to the sternum, and then you can see it continues to increase in density over time as well. So unfortunately, this one didn't show the classic early arterial enhancement and washout, but did continue to increase over time, and that turned out to be the location of the adenoma. So just a good reminder, these can go clear into the anterior mediastinum. We need to be vigilant in our search process. This is a final case, 73-year-old male with a history of ultramarital status due to hypercalcemic crisis. In this case, we saw a large multiloculated mass near the level of the esophagus, inferior aspect of the neck, heterogeneous in appearance with some early arterial phase enhancement, a little bit of washout. And just a good reminder, the question actually on this read was, is this a metastasis or something else? Are we looking at hypercalcemia due to, say, bone mets or some other reason? This is actually a large parathyroid adenoma, 3.3 centimeters in size. So particularly when they get large, they can be this heterogeneous on CT, and don't discount this. This might be a adenoma just because of the size and the heterogeneity of it. And then another heterogeneous mass along the posterior aspect of the left lobe of the thyroid gland. Again, low density on CT, non-contrast, so some real arterial heterogeneous enhancement and a little bit of washout. One other modality, because again, this is a really challenging space for us, just wanted to mention that there has been a lot of work looking at fluorocholine PET, either carbon fluorocholine or carbon choline or 18-fluorochlorine PET. It's been developed for parathyroid imaging. It shows high sensitivity and specificity, often even in multiglandular disease. And some of the papers are showing, say, 20 out of 21 cases where it's been fairly localized other places has been found on fluorocholine PET. So that might be something we'll be able to utilize in the future. One of the challenges, of course, making this commercially viable, given it's a relatively niche application. But certainly when it's available, it's shown great promise for potentially localizing some of the more difficult parathyroid adenomas. So the take-home points, we've shown several cases of how we localize these, both on ultrasound and on SESTA-MEDI and on 4D CT. Talking about, our sensitivity has increased with time with some of these different imaging tests, but we're certainly not perfect. And so it takes a team approach to really look at this. Oftentimes when we have a challenging case, there'll be all three of us taking a look at the exam and discussing where we think there might be some potential lesions, and then going on to doing things like the venous sampling, which I will then bow out and let Dr. Pinchot discuss.
Thank you, Greg. Are you guys able to see my screen?
Yes.
Okay, perfect. I just wanted to thank Dr. Sippel and Dr. Avey for that excellent introduction. What I'd like to talk about a little bit today is a subject that's become really a passion over the last decade or so here as a practice at the University of Wisconsin, and it's you know, it's a practice that I had never really thought about, as I wasn't exposed to it during my residency or fellowship. It was really only under the guidance of really having an excellent surgical department, and in particular, Dr. Sippel's tutelage, really for this program to develop. We've really become a preeminent referral center here nationally as a result of her excellent work and the excellent work of Dr. Avey and the diagnostic radiology department here as well. I kind of laugh at the title of my topic, Selective Parathyroid Venous Sampling, how to make it quick, easy, and successful. And that's because anyone who's done this procedure knows it's neither quick, it's almost never easy. But what I hope to show you today are tips and tricks to ultimately make this a successful procedure. I don't have any financial disclosures. What I'd like to talk about today is to introduce really what has become an increasingly rare technique. This is a technique and a procedure that's really done at very few tertiary care centers around the country. With that, I'd also like to review not only the embryologic anatomy of the parathyroid glands, because that becomes critical in how we do our venous sampling, but we'll also talk a little bit about the venous and arterial anatomy of the parathyroid glands. We'll talk about some of the anatomic challenges that are implicit to this technique, as well as technical aspects that really hopefully will ensure procedural success. If we look at the numbers, approximately 5 to 10% of patients who undergo surgery for primary hyperparathyroidism have persistent or recurrent postoperative hypercalcemia. And as Dr. Sippel showed, this can be due to just not finding the lesion at surgery, perhaps a missed second adenoma. Intrathyroidal, ectopic, or undescended adenomas can also come into play. We also know that persistent postoperative hypercalcemia could be associated with multiple adenomas, diffuse or nodular hyperplasia, and rare cases of parathyroid carcinoma. Obviously, in the reoperative patient, tissue plane distortion and scarring really makes this a technically challenging procedure. And so, as Dr. Sippel noted, having really good functional and anatomic imaging prior to perhaps undertaking reoperation is absolutely critical. And I think for that reason, using selective parathyroid venous sampling as a complement in the armamentarium of the very successful endocrine surgeon is absolutely critical. And so the advantages of preoperative parathyroid localization prior to minimally invasive parathyroidectomy really are that this procedure can be performed as an outpatient procedure. We bring our patients into our prep recovery area. It's about a 3 to 3.5 hour procedure, and then ultimately after a 2-hour recovery, they're able to go home. So it's a very easy sell for patients because they don't have to stay overnight with a lengthy hospitalization. We do know that this can facilitate unilateral neck dissection or minimally invasive parathyroidectomy, which obviously reduces operative time and morbidity, as well as improving cosmetic results. This does also leave a more favorable postoperative field for the surgeon in case reexploration becomes necessary in the future. And in those patients with recurrent or persistent hyperparathyroidism, it helps to detect both ectopic parathyroid tissue, perhaps in the mediastinum, or even the presence of supernumerary glands. With that in mind, selective parathyroid venous sampling, at least at our center at the University of Wisconsin, we reserve for definitive localization. And I put an asterisk next to this because I think definitive localization is a bit of a misnomer. I would say what I'm really doing with selective sampling is definitive regionalization. Is this in the high or the low neck? Is this in the mediastinum? Is it on the left? Is it on the right? Which is really the complementary functional data that has to go along with very good anatomic data that Drs. Avey and our diagnostic colleagues are obtaining as well. But we reserve this for regionalization in patients who've had prior parathyroid surgery and in whom non-invasive testing has been unrevealing or discordant. At our center, this typically is not used in those patients who are a primary operation. That tends not to be our practice, but there are centers that would use this in a primary operation or to help localize in a primary operation for a patient perhaps where non-invasive techniques have been equivocal or unrevealing. And ultimately, it's very helpful in patients who have suspected ectopic glandular tissue or potentially supernumerary glands where other non-invasive techniques have failed to show that. Selective parathyroid venous sampling was first described in the 1970s as a new method for localization and diagnosis of parathyroid tumors. And leading that charge was John Dopman, whose name is virtually synonymous with radiology at the NIH, where he served as chair of the diagnostic radiology department. He was a very skilled general and interventional radiologist who throughout his career really became the leading authority in the radiology of multiple endocrinologic problems, and he made that the focus of his career. Dotman recognized that the effective use of imaging really rested upon a firm understanding of the clinical diagnostic problem of hyperparathyroidism, and then also the pathophysiology of the underlying disease process. Perhaps more than any of his peers or contemporaries, I think Dotman recognized that a firm knowledge of the normal and ectopic locations of the parathyroid glands, and with that the embryologic origins of parathyroid tissue, were absolutely critical, but he also understood anatomically that understanding both the arterial and venous drainage pathways were essential to not only obtain but also interpret data that was received during localization procedures. I think it's important to note that whether we're talking about inferior or superior, upper and lower glands, those terms inferior and superior really do not indicate locations in the neck, but rather they denote the embryologic origin after normal migration of the parathyroid glandular tissue. The superior, the upper parathyroid glands develop from the fourth brachial pouch with the thyroid tissue, and they're closely associated as a result with the thyroid gland. Almost never are they found outside of the zone that's bordered by the upper border of the larynx or the lower pole of the thyroid gland. During their path of migration, I tend to think of them as very deep, somewhat medial structures. They can be retropharyngeal, they can be retrolaryngeal, or in the deep tracheoesophageal groove. If they do actually become ectopic, perhaps into the chest, we tend to think about these arising in the posterior mediastinum. On the contrary, the inferior parathyroid glands, they develop with the thymus tissue from the third branchial pouch. And so they have a much longer path of embryologic descent. They tend to descend and then move somewhat anterior and medially during this descent process, which leads to more variability in their location. These can really be found anywhere from the angle of the mandible all the way down to the pericardium. But I think the most frequent variants we tend to see are either in the thymus or in the mediastinum when they're ectopic. We can have patients who have supernumerary glands. It's rare to have less than 4 glands, but about 2.5 to 15% of the population in several large studies have been shown to have supernumerary parathyroid glandular tissue. With regard to ectopic parathyroid glands, these can really be one of the 4 parathyroid glands or supernumerary gland, and as I had mentioned before, they can really be found anywhere in the neck and mediastinum. As this table shows, the superior parathyroid glands, if ectopic, tend to be in a variant parapharyngeal, retropharyngeal, or retrotracheal position. I tend to think of these as deep, posterior, somewhat medial. When the inferior parathyroid tissues, as I mentioned before, are ectopic, they're almost always along the thyrothymic tract. And so they can be undescended in the carotid sheath, they can be intrathymic or anterior mediastinal, they can be intrathyroidal. And then supernumerary glands really can be located anywhere along the line of descent of parathyroid tissue during embryologic development. When we look at the venous anatomy of the neck, the parathyroid glands drain via the thyroid venous plexus and then predominantly downward via the inferior thyroid veins. There are 3 paired thyroid veins that form a valveless low-pressure thyroid venous plexus. This tends to exist on the anterior surface of the thyroid gland and anterior to the trachea. The number of inferior thyroid veins may range from between 2 and 5 inferior thyroid veins in multiple variant configurations. Some of the more common variants that we see I've kind of shown and depicted in these pictures above. So the image on the left is a high junction of both the right and the left inferior thyroid veins draining through a common trunk into the superior surface of the left brachiocephalic vein, typically near the confluence. The image in the middle shows a low junction of both the right and the left inferior thyroid veins, also draining along the anterior and superior surface of the left brachiocephalic vein near the confluence. And then the image on the right depicts a situation where we have completely separate drainage of both the right and the left inferior thyroid veins, again, both draining into the left brachiocephalic vein near the confluence. Occasionally when we see this third pattern, we'll see the right inferior thyroid vein actually drain into the right brachiocephalic vein just above the confluence. I think the summary point or the take-home point from these depictions, though, is that it's very important to maybe look at your pre-operative imaging prior to going in and undertaking selective parathyroid venous sampling so that you have some idea of what you're dealing with. I usually already know if I'm going to have to hunt down a separate right and a separate left, or if I'm looking at a common trunk from the neck CT that was done prior to me going in. In practice, this is what this actually looks like. So this is a venogram with a depiction of our catheter position in the right superior thyroid vein. And by virtue of this thyroid venous plexus being low pressure and valveless, typically if we can enter any of the paired thyroid veins and do an injection, we can fill the entire thyroid venous plexus. So we see paired right superior and left superior thyroid veins, which drain somewhat cephalad and then subsequently into the internal jugular vein on each side. The paired middle thyroid veins drain in a somewhat more horizontal fashion into the inferior jugular veins on each side. In this situation, we have a larger or dominant right inferior thyroid vein, which joins together with the smaller diminutive caliber left inferior thyroid vein. They form that first pattern on the prior cartoon depiction, where both of the inferior thyroid veins come together into a common trunk, and then subsequently drain into the left brachiocephalic vein near the confluence of the right and left brachiocephalic veins. Another variant of this anatomy, though, is this image that you see here, where we again see normal appearance of the paired superior thyroid veins, again coursing somewhat cephalad into the internal jugular veins. On the left, we definitely have a left middle thyroid vein which drains into the IJ. On the right, we don't see really a normal appearance of the middle thyroid vein. More often than not, especially in reoperative patients, one or both of the middle thyroid veins may have been ligated, and what we do tend to see is collateral venous flow or parasitic venous flow coming from one of the thyroid veins. So in this situation, we actually have parasitic drainage from the right superior thyroid descending inferiorly into the internal jugular vein. And you can see the inferior thyroid veins are actually draining completely separately into the brachiocephalic vein. This is just another really good example of not stopping short of being super selective on these procedures. In the image on the left, we see our catheter position in the right superior thyroid vein. And our general sense is that there's a common trunk draining into the brachiocephalic vein inferiorly, but when we get more selective and deeper into the thyroid venous plexus, what we actually see is that there is a small diminutive caliber left inferior thyroid vein, which actually joins up with that dominant common trunk. And so it's very important that we actually sample from both of those locations so as to provide lateralization information for Dr. Sippel at the time of surgery. In the mediastinum, venous drainage can be highly variable, much more variable than we tend to see in the neck. But in most cases, mediastinal glands, when they exist, they typically drain into one or two more common sites. The first is what we call the thymic mediastinal veins, or the thymic veins. There is a left and a right thymic vein. The left thymic vein typically drains into the anterior surface of the left brachiocephalic vein, and I'll show you some examples of that. The right thymic vein tends to be very, very small in caliber in most patients, and because it drains directly into the superior vena cava, it's exquisitely difficult to find and almost never successfully catheterized. We can see mediastinal glands also drain into the internal thoracic or internal mammary veins. I'll show you an example of that on an upcoming slide. Or sometimes we'll see direct drainage into the inferior thyroid common trunk if they're located higher in the superior mediastinum. Oftentimes in post-surgical patients, the vertebral veins can become a very dominant drainage pathway for mediastinal glands, and so it's very critical. And this is something that I've actually started adding in the last 5 years or so to my venous sampling procedures. I typically didn't sample those early on in my experience, and as I've started to recognize that post-operative patients oftentimes collateralize their flow into the vertebral veins, we've started to go after these more and more. And the vertebral veins ultimately drain in somewhat of a posterior medial location to both of the internal jugular veins. So they're rather easy to find, albeit difficult to get into because of a subterminal valve they have just prior to their drainage. This is an example of catheterization of the thymic mediastinal vein, again, because it arises somewhat anteriorly or drains somewhat anteriorly into the left brachiocephalic vein. It's a bit of a tricky location to get into. Scott Traertola at the University of Pennsylvania described a technique that he calls the twisted SIM technique, where he actually takes a Simmons 2 catheter and twists it upon itself, which subsequently leads to the catheter directing its tip anteriorly. And this is a very successful technique we've used to engage the thymic mediastinal vein in quite a few patients. Here's another example of that twisted SIM technique successfully engaging that thymic mediastinal vein. Occasionally you get lucky and you can use a shaped catheter such as a Davis or a Bernstein catheter to look straight down as you get in, if it's inserting somewhat low and anterior on the brachiocephalic vein. And so in this case, we're successfully using a Davis catheter and a prograde microcatheter to engage the thymic mediastinal vein in a somewhat downgoing thymic mediastinal vein coming off that anterior inferior brachiocephalic vein. It is critical to recognize that the thymic mediastinal vein can have aberrant or very anomalous venous drainage patterns. This is a situation where we saw a very robust communication between thymic mediastinal venous drainage and the common trunk of the inferior thyroid vein. And so you can see my arrows actually denoting a common trunk of the right and the left inferior thyroid veins draining into its normal location of the left brachiocephalic vein. But we also see these thymic veins draining cephalad toward that common trunk and then subsequently into the brachiocephalic vein. So it's very important that you sort this out. You spend some time mapping out the thymic mediastinal veins in particular if you suspect ectopic or supernumerary tissue. This is a situation where we use a Davis catheter and put a microcatheter directly into the left internal thoracic or internal mammary vein. We engaged that quite deep and we sampled here, and I want you to note that there is quite a bit of cross-filling to the right side, the right IMV, and this is typical cross-mediastinal drainage, and then actually cross-drainage we tend to see in the anterior thoracic wall as well. With regard to procedural preparation for selective venous sampling, it's critical that you review and know the prior surgical history. A lot of times, because we're a tertiary referral center, we're getting that history from outside hospitals. We do hunt down those surgical op notes, even if they date back a decade or more, to make sure that we know which glands were removed and which ones were left behind, because that certainly allows us to hone in on what we need to find. It's also important to review prior non-invasive localization studies. So if they've had 4D CT, sestamibi, ultrasounds, all of that, we want to have that at our fingertips as well to really focus our efforts on the region of concern. It is critical to make sure you have all the products available to you for this procedure. You may have to go through multiple different catheter shapes and sizes to actually get into many of these veins. So you're going to make sure you have those on the shelf before you undertake one of these procedures. And something that I really didn't put a whole lot of thought of when I started this, but it's become a really important part of our practice, is collaboration with your laboratory services. We've had to really sit down with our inpatient laboratory to make sure not only were they prepared to receive these samples, because they're receiving them in real time, acting on that information and getting it back to us almost immediately. So you have to have somebody at the window of the lab kind of ready and willing to receive these and process them expeditiously. But it's also critical that reference values for your lab are all validated. And so early on in our experience, we weren't able to validate parathyroid hormone levels that were greater than 500 until we really kind of collated our results with several outside reference laboratories that were able to go to much higher levels. So a lot of times we're getting results back that just said greater than 500 for our parathyroid hormone levels, rather than what we get now, which is greater than 2,500. The technique itself is performed by Seldinger Technique. We obtain venous access through the right femoral vein. I like to put in a long sheath, like a shuttle sheath, so that I can do catheter exchanges quickly without having to negotiate the right atrium every time I do it. We use a variety of shaped catheters, and I'll show you some pictures of those shaped catheters that we typically use. From each of the sites that we're actually collecting blood, we obtain about 2 to 3 cc's of blood. We first obtain a level from the right iliac vein, which serves as our baseline level. And then we obtain small aliquots of blood from 23 additional sites throughout the neck and mediastinum. These are some of the shaped catheters that we use. The workhorse really that we like to use is either the multi-purpose or the Davis catheter, because they tend to have a shape that really is quite efficient to get into multiple of the thyroid veins. I generate a gradient map as we sample, and this is actually what our gradient map looks like at the University of Wisconsin. So we sample from 24 different sites. This is a very laborious and lengthy process. I first try to obtain samples from pretty much all of the large veins, so the internal jugular veins on each side, both high and low. We do subclavian and innominate veins on both sides as well as the superior vena cava, the right atrium, the inferior vena cava, and the azygos vein. Only after I've obtained all of those samples do I start to hone in on some of the smaller veins. And the reason I actually do it in that order is because as I'm working, I'm actually getting real-time data back on levels from all of these locations. And for instance, if the right internal jugular vein shows a step up in parathyroid hormone level between the high and the low, internal jugular vein, I now have to really interrogate the superior and the middle thyroid veins on the right side with you know, a little bit more effort and a little bit more concern, because it's likely that one of those two branches is actually resulting in that step up that we see. Okay. Selective venous sampling is positive when the parathyroid hormone level obtained from one of the smaller sampled veins is 1.5 or 2-fold what the circulating background level is that was obtained from the iliac vein at the beginning of the procedure. There have been several studies that have looked to validate these threshold values, and I think two of the better studies and the larger studies that have been published in the last several years looked at threshold values ranging between 1.5 and 3 times background. Ogilvy et al. Looked at the positive predictive value of venous sampling at 1.5, 2.5, and 3 times background, and they found that that positive predictive value was 72% at 1.5 times background, all the way up to 83% if we have more stringent thresholds sampling at 3 times background. Labashi et al. In 2015 had a very similar experience where they found a sensitivity of 86% and a positive predictive value of 93% when they used a gradient or a step up of greater than 2 to 1 during selective parathyroid venous sampling. A really eloquent study that came out of a single institution just recently in the journal Surgery. This came out just this year. This was a tertiary care parathyroid center that looked at almost 500 patients, and they were looking at kind of different areas where they saw step-ups in gradients throughout the neck and the mediastinum. And not surprisingly, they were noting most of the step-ups were located in the mid and the inferior thyroids. We had lesser numbers in the brachiocephalic and the superior vena cava, and even less so in more ectopic locations of the mediastinum, like the left superior mediastinal or thymic veins in the left internal mammary vein. When I do sampling, I do venograms from all of the major large veins as well as the smaller veins. This is really important because it's critical that as you obtain your values, you know where your catheter position was for each of those samplings. And so this is just a picture of the right internal jugular vein. This is a picture with our catheter into the inferior thyroid vein, and you can see again, because it's a low pressure valveless plexus, as we inject, we can see both paired superior and middle thymic veins, as well as a very rudimentary diminutive caliber inferior thyroid vein on the left side. This is just another appearance of a thymic mediastinal vein with multiple small drainers going into it. We do a picture from the right subclavian vein as well as the left subclavian vein, and then this is a picture from the azygos vein. We do know that if there's ectopic tissue, in particular upper glands that are ectopic, their path of descent, again, as I have talked about, tends to be very posterior. So if an upper gland is ectopic, it can be as low as the posterior mediastinum, which we'll sometimes see drain into the azygos vein. And then this is a picture of the left internal thoracic or internal mammary vein. My table setup really looks like this. We have 24 samples pretty much laid out, all properly labeled. So as we work our way through each of the veins, we're very quickly able to grab each numbered syringe, which corresponds to the location we're sampling, and then pass it off onto the table. And then our nurses essentially put those into red top tubes and quickly run those to the laboratory. I don't always do these in order. I do not go 1 through 24. I typically grab them as I land into each vein. This is an example of a study we had done several years ago. Before I had done 24 sites. At this time, I was only doing 20 sites. But what we see is that we see a significant step up or gradient in the middle thyroid vein on the left. This is a patient who had a PTH level from the middle thyroid on the left side that was over 2 to 1 when we look at the background being 224. So we had surmised this was likely an inferior gland in the lower left neck. And on imaging, we see this very, very small area of enhancing tissue. This is in a patient who was post-thyroidectomy. This was initially called remnant thyroid tissue, but this turned out to be a parathyroid adenoma in the lower left neck. And there it is on ultrasound. This is another study where we had very, very high levels from the left middle thyroid vein, as well as the left inferior thyroid vein. And then you could see step down gradients as we get into the innominate, the superior vena cava, and the right atrium, which is fitting as we see drainage kind of coming down from that low left neck location. The other thing I want to make note of is that we see considerable step up between the high internal jugular vein on the left, where the parathyroid hormone level was 155, which is nearly equivalent to our background level of 130, to the low IJ, which was 903. So we saw that significant step up, which really told us we needed to hone in on drainage going into the left internal jugular vein, and that's why we really spent time going into that middle thyroid vein on the left side. There are some centers where they will corroborate findings from their selective venous sampling with selective parathyroid arteriography. This is not part of our practice at the University of Wisconsin, but I want to just talk about this passingly because it is somewhat of an interesting technique. And doing parathyroid arteriography obviously often relies on your knowledge of the arterial supply to the parathyroid glands. And so the superior parathyroid gland about 85% of the time receives its blood supply from the inferior thyroid artery and a lesser 15% from the superior thyroid artery, which is a first descending branch off the external carotid artery. Occasionally, we'll see an artery called the thyroidia ima artery, which is also called the thyroid artery of Neubauer. This is really kind of an atypical origin of the inferior thyroid artery off of either the aorta directly or off the brachiocephalic trunk, as you see on these images on the right, in both the fluoroscopic image, where it's denoted by a small black arrow, as well as the maximum intensity projection image that you see below, where it's denoted by the white arrow. The red arrow denotes the vertebral artery on the right side. The inferior parathyroid gland almost always, nearly 100% of the time, receives its arterial blood supply from the inferior thyroid artery. Ectopic, anterior mediastinal, or intrathymic tissue can receive blood supply from the inferior thyroid artery, a thymic branch of the internal mammary artery, or the thyroidia ima artery as well. This is a really good example. This is not mine, but this is from a paper written by Scott Trout out of Penn, where during selective venous sampling, when they were in the thymic mediastinal vein, they surmised that they saw a small blush, or small plexus of tissue in the anterior mediastinum. And to confirm that, they actually did arteriography, and in the middle image, their catheter is actually in the inferior thyroid artery, and we see this hypervascular blush corresponding to what they saw in the venous imaging. They also went into the internal mammary artery. That's the image that you see labeled C, where we actually see a thymic branch actually coursing medially off of the internal mammary artery and also supplying portions of that adenoma. Okay. So pitfalls of selective venous sampling. Catheterization of the veins is probably the biggest pitfall. You have to be a very patient interventional radiologist. This oftentimes takes 3 or 4 hours to get through all of these tiny veins. I've spent 2 hours trying to get into a single vein on occasion. Aspiration of the venous specimen is quite difficult, just like adrenal vein sampling. Sometimes these veins are so small that they will collapse. So there are some techniques like puncturing a small hole in the tip of the catheter or near the tip of the catheter, or even putting an 018 wire through your base 4 French or 5 French catheter to keep the catheter tip off the wall to facilitate improved drainage. Sometimes I'll let it passively drip into a syringe as well. The vertebral and internal jugular veins have valves right at the point where they join into the subclavian veins, and so they can be quite difficult to access from below. Oftentimes you can have a patient hyperextend the neck in Valsalva, and as you spin your catheter, you'll pop into those internal jugular veins. And then ultimately, we're doing this in post-operative patients where they have altered venous anatomy. And so oftentimes, because things are ligated, we're seeing a lot of parasitized and collateral venous flow from other sites. Okay. Overall, despite the technical challenges, there are very few complications ever reported with this. Okay, so the take-home point, the overall impact of parathyroid venous sampling on outcomes, it's not been studied. It certainly warrants further investigation, but I think we've got pretty ample data from several really well-designed studies that have looked at how well we're able to correlate our parathyroid venous sampling results with the operative findings. And 2 of the better designed studies that came out in 2016 and 2018, and the first by Habibola et al., about 81% of patients, the surgical findings correlated with what was found at parathyroid venous sampling, and that was in over 30 patients. A smaller study looking at just under 30 patients, 26 patients who had primary hyperparathyroidism, In 16 out of 19 patients, so 84%, the parathyroid venous step up was concordant with what was found intraoperatively at the time of localization. So very, very good data suggesting that this does improve surgical outcomes, and 80–90% of the time will help the surgeon with localization to really permit minimally invasive parathyroidectomy. Okay. We're going to skip this slide just for the sake of time. It really kind of rehashes the same point that this is really helping the surgeon, especially in situations where our other non-invasive imaging has perhaps been discordant or really unhelpful. So thank you for your attention, and happy to answer questions at the end of this. I think I'm going to turn things over to Dr. Sippel once again, because I think she has several companion cases just to kind of highlight how the three of us have worked together to really kind of bring about good outcomes here at University of Wisconsin.
Dr. Sippel, you are muted.
Well, thanks for letting me know. It's like you would think after this point I wouldn't know how to do that. So can you guys see my slides okay?
Yes,
thanks.
Okay, perfect. So this is just a case. I just wanted to sort of show how it's able to help us help patients. This was a 28-year-old woman who had very mild disease. She had had a previous bilateral exploration, and they had removed 2 parathyroids, a right upper and a left upper, but they couldn't find the lower glands. And she had persistent disease and was interested in pursuing treatment, but her disease is very mild. So we aren't looking for a huge adenoma. We're looking for a relatively small gland. So we got an ultrasound, and the thyroid had thyroiditis. There was no nodules, and there was no lesions seen outside the thyroid. So then she got a CT scan, and no lesions were seen, although there was a question of a 5-millimeter enhancing nodule in her left thyroid. So based on that, we looked back at the ultrasound, but there just didn't seem to be a good correlate of anything inside the thyroid that matched that. So this was a patient who I just didn't feel like we had any good localization. So we referred her for selective venous sampling. And this is just an example. I don't have the beautiful diagrams that Dr. Pinchot has, but this is sort of the reports that we typically get. And as I look at it, what I'm looking for is what the baseline level is and where the elevations are. And in this, you can see that the superior thyroid vein is 500, the right middle thyroid vein is 239, and the right inferior thyroid vein is 308. And all of the rest of the values are really, at a peripheral or systemic level. So I don't know, Dr. Pinchot, if you want to talk at all about sort of your interpretation of these results.
Yeah, and so I think what this very clearly shows us is that we have overproduction of parathyroid hormone in the right neck. Oftentimes, again, because it's a valveless plexus, we'll see drainage, superiorly as well as inferiorly. But what this really shows me is that the dominant drainage is through the superior thyroid vein, more so than inferiorly into the inferior thyroid vein. So I would probably localize this to the right neck in more of a higher location, so at or above the thyroid gland.
Exactly, and I think for me as a surgeon, my other imaging was suggesting, if anything, something on the left. So this localization very convincingly tells me it is not in the left neck. There's no elevation at all, so it means that I can really focus my operation on the right neck. And that gives me an opportunity to go in a reoperative field and focus on just one side of the neck. So we took this patient back to the OR and explored the right upper neck and found a right upper parathyroid adenoma that was identified and removed. And her intraoperative PTH levels then fell from 105 to 34, and her labs are consistent with a cure. So her PTH isn't super high. This is not really significant disease, and we're not looking for huge glands, but the selective venous sampling is so accurate that it really allows us to offer reoperations to even patients who have relatively small glands. So the next one is just an example of a 74-year-old woman who had recurrent hyperparathyroidism. She actually had a previous surgery in 1988 and had a right upper parathyroid removed, an adenoma. And her post-op labs were consistent with a cure, but she now developed recurrent hypercalcemia just 2 years ago, over 30 years from her original operation. And she comes in to discuss a reoperative parathyroid. So we start with an ultrasound, and there's a hypervascular nodule in the left thyroid, also a hypocoax structure posterior to the left thyroid. So I'm thinking, okay, could be intrathyroidal, could be behind the left thyroid. Those are my two most suspicious areas. So I get a CT scan, and the CT scan shows those same things. It shows a hyperenhancing intrathyroidal lesion in the left lobe, and an additional 7mm lesion located posterior to the left thyroid lobe that was suggestive of a parathyroid. So here I had two anatomic things suggesting the left neck. So I thought, okay, I should just go to the left neck. She's had the right previously removed. But then I got a system Avey scan, and there was no activity in the left neck. So made me start to question things. So then I thought, well, I should do a FNA, and I did an FNA of the thyroid nodule, and it came back negative. It wasn't elevated for parathyroid hormone level. So at that point, even though I had two anatomic lesions in the left neck, I thought, I really should probably do selective venous sampling. So I sent it to Dr. Pinchot, and this is what we got from the selective venous sampling. So when we look at this, again, levels over 2,000 from the superior thyroid on the right side. The low internal jugular vein is also elevated, the right inferior thyroid is elevated, and everything else is at baseline. So I don't know if you want to.
Yeah, so I think what this again shows is very similar to the prior case. The first thing I really want to note is the considerable step up between the right high internal jugular vein, where it measured 92, actually below background, and the low internal jugular vein, where it measured 352. So right away, we know that there's drainage into the right internal jugular vein. We don't see a similar step up on the left, where it only really is 71 to 91, so very similar to background. So that already has our suspicion high, quite high, that we need to look at the superior and the middle thyroid on the right side. In this situation, more often than not, when we're unable to catheterize the middle thyroid, it's because it's previously been ligated, but we do see that superior thyroid is 2475, and it probably was greater than 2475 because that's the upper limits of where our test is validated. So that could have been much, much higher even than that. And then we see lesser drainage into the right inferior thyroid. So this, again, is likely in the right upper neck.
And this was just incredibly helpful because my other imaging was really suggesting the left neck, and I was pretty close to just operating on the left neck based on that. And thankfully, I sent this patient for the venous sampling because it completely changed the direction. And interesting, localized to the right upper, which is the one gland that supposedly had already been removed. So that should have been the one it wouldn't be. But that's what it suggested. So we went in to her case and explored her right upper neck and found that next to the clips from her previous right upper adenoma resection, there was a recurrence. They hadn't removed 100% of the gland and it had regrown. So again, we removed that. The intraoperative PTH levels fell appropriately and our labs are consistent with the cure. So this was just another case where the selective venous sampling really allowed us to provide a focused reoperation that was successful, where other imaging just wasn't going to present that as an easy option for the patient. All right, so those are the end of my cases. I hope that you guys have found this helpful. I know that for me as a parathyroid surgeon, I am so grateful to have the help of such amazing colleagues in radiology and interventional radiology, because I think these are hard operations and we can't do what we do without their help and support. And I am so lucky to have such qualified people who can really give us the imaging guidance to allow us to offer options to patients that otherwise wouldn't be able to have successful surgery.
Well, thank you very much to all of you for taking time to give us that amazing tour de force on this complex topic. I'm curious if you have any time for questions or if we should stop for tonight.
I am happy to take questions.
Same here.
Okay, thank you very much. So Dr. Pinchot, a quick question for you. Obviously, mapping out the anatomy is totally crucial to getting this right. Do you ever find cone beam CT ever useful for mapping out the vasculature, or is just a conventional venogram your go-to?
We typically don't need cone beam CT. We'll do the conventional venogram. And again, I think success really rests. You have about, you have six thyroid veins, and all you have to do is get into one of them. And if you get into one of them, you're generally able to see the entirety of the thyroid venous plexus, which really is the largest battle. You get into that thyroid venous plexus, you can actually catheterize the middle and the superior thyroid veins in a retrograde manner. And fluoroscopically, you're able to see the drainage where each of those parathyroid veins may drain into the brachiocephalic vein if it's the inferiors, or into the internal jugular vein on each side. So I think it's a really interesting idea for sure, using cone beam CT. I think it's certainly something that I haven't needed to use in practice. But it certainly potentially has future use if if we find that this might help us localize some of those harder veins, perhaps in the mediastinum.
Interesting.
I think the other thing that, and I'm just going to say, because I know that you've talked to me about doing it, is that because you get the results real time, you'll see that super high level, and then can go back and get additional samples in that immediate region to really show us that sort of step down. Because I think that step down is absolutely key to convince me that that's the localization. Because I think if you get really close to even a normal parathyroid, you can get one isolated level that's 2000. But if nothing else around it is elevated, I'm not as convinced. But if you see that 2000 and then you see the veins that would drain, so think about what the anatomy is and how that would drain to get down to the heart, and each of those is above background, that's really convincing.
For sure. I think where it gets a little bit tricky, and again, we're kind of looking at that step down as critical, is perhaps that situation where you have very robust drainage from a thymic mediastinal vein into a common trunk of the inferior thyroid veins, because your inferior thyroid vein levels tend to be off the charts. But if you don't get very selective into those thymic mediastinal veins, you'll make the assumption that it's coming from the neck. And so it's very critical really to map that out to the best of your ability. And that just takes time, and it takes patience.
So along the same lines of getting it right, Dr. Avey, I know you mentioned that this was sort of a hot topic at the recent national meeting for head and neck society meeting. Curious if you learned or are aware of any assistive technologies like AI that have been used to help interpret these kinds of studies.
Yeah, I'm not aware, at least, of an AI program that's been developed for that. I'm certainly could. Part of the challenge is probably finding enough high quality cases that we actually have path proof for and that are accurate. So of course it's the standard sort of AI problem with that. That would be something we could potentially do for the future or to look at. But again, part of the problem is even our AI that have quite a lot of validation, say for cervical spine fractures and that sort of thing, we're finding accuracies or sensitivities in the 90% range or 95% range. That's unfortunately where we're falling right now, just without the AI. So it might be an extra tool to help, but I'm not certain if we would have enough data to be able to really make that happen.
Makes sense. It's a complicated job to do. And then Dr. Sippel, it sounds like some of the most complicated cases for you involve patients who've had reoperations. Is there a particular clinical scenario that comes to mind when you think of the most challenging cases for you?
I think, if somebody is a reoperation and they've had a relatively focused operation, it's a pretty easy reoperation. I'm not too concerned about that. Or if the first surgeon just doesn't have a lot of experience, then I'm not too worried about it. But if they have had a surgery by a very experienced surgeon who couldn't find something, or sometimes you'll get the operative note and you'll see that it was a 6-hour operation and they looked everywhere and they biopsied everything in the neck, and they ligated every vein, then I just know that it's not going to be fun from my standpoint from a scar tissue. But I also know because they ligated all those veins, I'm also going to make Dr. Pinchot's job that much harder, that he's not going to be able to give me the information because he's not going to be able to get close enough to the areas that we need. Because in those cases, the drainage often is very unusual, and then it becomes a little bit harder to understand where that maps to in the imaging. And so that's why I do think usually when I get the venous sampling, I get a CT scan at the exact same time, because, or a few days within it, because I really want to map what he gives me from the venous sampling with that CT image, because once he gives me a region, then we can look at the imaging and really say, okay, this is where the activities are, is coming from. What in this area potentially could be the source of where that's coming from.
It makes a lot of sense. Thanks for going through that. Well, I don't see any more questions in the chat for now. So I think we can probably conclude, unless any of you have any other parting thoughts. All right, well, I want to thank you again all for sharing your expertise and time on this Thursday evening. Really appreciate your expertise on this topic.
All right,
Thank you all.
Thank you for being invited. Have a good evening.
All right, thanks so much. Take care.
Good night.